Hello everyone, Medical Level Up here. We're back again with another video. Today's video is going to be about primary headaches. For those of you that didn't check out the previous video, which was on secondary headaches, I'm going to leave a link in the description and I'm going to leave a card up on the video so you can watch that as well. Let's get started with primary headaches. Now before we start, I would highly appreciate if you could drop a like to the video and a subscribe to the channel since it is going to help our community grow. Right, let's get the lazy board up first. The first primary headache we're going to be discussing, and by far the second most common primary headache, is a migraine. Before we discuss the symptomatology and the kind of aura associated with migraine, we're going to talk about the pathophysiology because I think it's a bit interesting. The pathophysiology of migraine is basically twofold. First, there is a thing called cortical spreading depression, which is a wave of depolarization that spreads over the entire cortex, and it is responsible for also activating the trigeminal vascular system. Now, both of these things are responsible for activating the trigeminal nerve afferents, which in turn will stimulate the pain-sensitive meninges and also the release of pro-inflammatory mediators. The pro-inflammatory mediators are substance P, CGRP, and neurokinin A. CGRP, also known as calcitonin gene-related peptide, is a potent vasodilator. Before we move on, there are a lot of triggers for migraines. I'm going to leave a list up on the board for you guys to see the potential triggers that cause a migraine. Among these, the topmost are going to be stress, missing a meal, not having enough sleep, hormones in women, and among other things. Let's talk about the symptomatology now. In 77% of migraine patients, there is going to be a prodrome before a migraine. Now, this prodrome is thought to be caused by the cortical spreading depression we talked about earlier. And these symptoms can last anywhere between 24 to 72 hours. The symptoms are going to be yawning, depression, fatigue, irritability, and neck stiffness. We've been typically taught in medical school that aura can precede a migraine headache. But I'm here to tell you that an aura and a headache is going to coexist simultaneously as well. Aura is anything less than an hour, but it typically lasts 20 minutes in duration. A very characteristic feature of aura is that there is going to be complete reversibility of all the symptoms. Now, there is going to be positive symptoms and negative symptoms. Positive symptoms in an aura is when there is active discharge in a part of the brain that causes these symptoms. Now, there are 4 different types of positive auras, which is visual aura, auditory aura, motor aura, and sensory aura. Negative symptoms are basically the absence or loss of a symptom. Now, there is loss of vision, loss of hearing, or inability to move a limb or an arm. Now, the first one is visual aura. This can have scintillating scotoma, which is an area of bright light around area of darkness or loss of vision. It can be a shade, or a sickle, or a C shape in their vision. The second one is tecopsia. Tecopsia means that there is a perception of a visual image when the person's eyes are closed. The third one is a fortification spectrum. So a very good trick I've learned is that you can show them images on Google for fortification spectrum to see if your patients state that this is exactly what they saw before the headache started. The last one is a photopsia. Now remember that these flashes of light in a migraine are going to be colored. Do not confuse them with the flashes of light that happen with retinal detachment. This is a great clinical pearl. If the flashes of light are colored, it's a migraine, and if the flashes of light are black and white, it can be a retinal detachment. The second thing is a sensory aura. Now, patients can complain of tingling, which crosses from one side of the body to the other side of the body. Remember that migraines march, and this tingling can be a clue to the marching nature of a migraine. This tingling can also be followed by a numbness in the area as well. The third thing is a language aura. Language aura can range from anywhere from mild word-finding difficulty all the way to frank dysphasia. The last one is a motor aura, and we've also heard about hemiplegic migraine. So you can have weakness of the face, the arms, the limbs, anywhere. But remember that there is complete reversibility of this paralysis. Now, there is also an entity of a migraine which is interesting to know, which is a migraine without aura. So none of these aura symptoms are going to be present in that type of migraine. It's time to talk about the actual headache. Let's start off with the mnemonic. The mnemonic is POUND. P for pulsatile nature, O for onset less than 72 hours duration, U for unilateral in nature, N for nauseating, and D for disabling intensity. If there is 4 out of 5 symptoms present, the positive likelihood ratio for it being a migraine is 24. If there are 3 symptoms present, the positive likelihood ratio for it being a migraine is 3.5. I would take this mnemonic with a pinch of salt because I'm here to tell you that 50% of migraines do not throb. 50% of migraines are not unilateral in nature, and 80% of migraines will have neck pain. Now that is important because you've always been taught that if there is neck pain, it's a tension type headache, and I'm here to tell you not so much. There is another S that is being added to the POUNS mnemonic, and the S stands for sensitivity to light and to sounds, which is photophobia or phonophobia. There's another symptom known as cutaneous allodynia. Now that just means that there is increased response to pain or pain felt when you touch the skin of the patient during a migraine attack. In one study, 62% of patients said that they had cutaneous allodynia by a self-reported questionnaire. Now there are different types of migraine. Namely, these are vestibular migraine, migraine with brainstem aura, retinal migraine, menstrual migraine, and a hemiplegic migraine. We'll discuss each of these in a little bit detail. Migraine with brainstem aura, which was previously known as a basilar artery migraine, is going to present with symptoms such as vertigo, tinnitus, diplopia, dysarthria, loss of consciousness, and hyperacusis. Usually there is loss of consciousness with a headache, but only make this diagnosis when there is a second brainstem sign present at the same time. You can have also a retinal migraine or an ocular migraine in which there is going to be visual loss, but it is going to last less than 1 hour and it is totally reversible. A vestibular migraine, as the name suggests, is going to be associated with vertigo. A menstrual migraine, as the name suggests, will have close temporal relationship to the onset of menses in women. The most common days are 2 days before the onset and 3 days after the cessation of bleeding. I'm going to leave a picture up on the screen, which is going to let you know about the International Classification of Headache Disorders version 3, which is used to diagnose the diagnosis of a migraine with aura and without aura. The next headache we're going to be talking about is a cluster headache. We're going to cut away from my face and look at an image which is going to explain the pathophysiology of a cluster headache, and I think this is quite important in understanding the symptomatology. So of course, first of all, you need a brain to have a headache in the first place. Let's draw the cortex and label it. Then we draw the hypothalamus and label it. Next, in purple, I'm going to draw the trigeminal nucleus caudalis. All of these 3 things are connected together. So the cortex is connected to the hypothalamus, and then in turn that is connected to the TNC. The trigeminal nucleus caudalis is then connected to the superior salivatory nucleus. And after that, we're going to draw the 3 divisions of the trigeminal nerve, the ophthalmic division, the maxillary division, and the mandibular division. So let's draw a nose and an eye, because I think these are important in the pathophysiology of this headache. So the superior salivatory nucleus is then again connected to the sphenopalatine ganglion, which obviously innervates parts of the eye and parts of the nasal cavity. So when these are stimulated by the trigeminal nucleus caudalis, you will have tearing from the eye, redness, facial edema, rhinorrhea, and that's how the mechanism works. Now, a patient with a cluster headache is going to have a headache that is much more severe, sharp in nature, stabbing in nature, and as compared to a patient with migraine, this patient is going to be a lot more restless. Remember that migraines hate movement, but clusters don't. So a restless patient is a patient with a cluster headache. Other features of a cluster headache is that there is going to be periods of remission, there is also going to be cutaneous allodynia, and the headache is usually distributed retroorbitally, around the eye, or in the temporal region. I'm going to leave a picture on the screen again for you guys to see the ICHD3 diagnostic criteria for diagnosing a cluster headache. The next set of headaches is going to be the trigeminal autonomic cephalalgias. Now there are three important headaches in this category, which are hemicrania continua, hemicrania paroxysmal, and short-lasting unilateral neuralgiform headache attacks. Paroxysmal hemicrania and hemicrania continua are pretty much the same kind of headache but on different ends of the spectrum. Now these TACs not only present with a headache, but they will also have some degree of autonomic features that are related to the trigeminal nerve. Now these can be lacrimation, ptosis, meiosis, eyelid edema, or facial edema. A very important characteristic of TACs is that they are very responsive to indomethacin. Now these patients can be restless and agitated. They can report the characteristic of the pain as stabbing in nature. The mean age at onset of these TACs is usually the same for both headaches, which is 34 to 37 years. Now another type of headache is short-lasting unilateral neuralgiform headache. Now, as is evident from the name, these are going to be stabbing or sharp in nature. They can happen in any of the three divisions of the trigeminal nerve, the ophthalmic, the maxillary, or the mandibular, and they will be associated with autonomic features. Now when it comes to the duration of these headaches, a single stabbing headache will have a mean duration of 58 seconds. Repetitive stabbing headaches will have a mean duration of 180 seconds. There is a sawtooth pattern as well, which will have superimposed headaches, and the median duration for that is 240 seconds. And then there is a last type where there is a plateau type attack, which is mean duration of 300. This kind of headache can have interictal pain in 53% of patients. This has no refractory period in 90% of patients, and some patients will also report trigeminal region allodynia or hyperesthesia. Now the last major headache to talk about is a tension type headache. The prevalence of this headache is as high as 86% in a year according to a study. This is the most common type of headache diagnosed. It is more prevalent in women as compared to men. Patients will describe a bilateral non-throbbing headache, and the character of the pain is going to be described as a dull pressure, heavy weight on the shoulders and on the head, a band-like or a tight cap around the head. Remember that 14 to 20% of these patients can also have pulsatile pain as well, and then 10% of patients will have this pain in a unilateral distribution. The most important examination finding that you can do in these patients is looking for pericranial muscle tenderness. The muscles that you're going to be palpating is the temporalis, the masseter, the pterygoids, the occipitofrontalis muscle, the sternocleidomastoid muscle, and the trapezius. In one study, there was reduced neck and shoulder strength in female patients with tension type headache. Remember that there is no ongoing inflammation and there are no inflammatory metabolites during the attack of a tension type headache, and the muscle that was used to check this was the trapezius. As the name implies, a tension type headache is going to be triggered by stress or mental tension, but bear in mind that stress and mental tension have equal propensity to cause a tension type headache or a migraine as well, so this risk factor doesn't really help us at all. Be very careful when you're labeling someone as a tension type headache. There are two studies that I want to quote over here. The first one was the landmark study. In 1,203 male and female patients who were asked to keep a record of their headache in a diary, 94% of these patients turned out to have a migraine or a probable migraine according to the ICHD3 classification. There was another study called the Spectrum study in which 32% of patients turned out to have a migraine but were initially labeled as a tension type headache when they were compared to the ICHD3 classification. There are 4 more headaches that need to be discussed. Now these are primary headaches and they are self-resolving. The first one is a primary stabbing headache where a patient will complain of stabbing headache in one side of the face, and these will have no autonomic features, and these cannot be fit into any other headache classification. The second one is a hypnic headache. Now hypnic headaches typically tend to occur when a patient is asleep and they wake you up from your sleep, and they can last anywhere less than 2 hours in duration, and they will happen more than or equal to 15 days per month. The third one is a cold stimulus headache, also known as a brain freeze. So when you're having something very cold, when you're having cold ice cream, and when the ice cream touches your palate or your pharynx, there is a transient headache, and that is called a cold stimulus headache. The last one is a cough headache, and that tends to happen when you're repeatedly coughing. That is all there is to know about headaches. I hope the next time you're seeing a headache patient, you have this newfound confidence in diagnosing a patient with a headache. Thank you so much for watching, and have a good day. That's all for today. Let me know in the comments section if this was helpful or not. Don't forget to like, share, and subscribe to the channel, and have a good day.